Well, sí, vamos a empezar así. Gracias. Bueno.
All right, we can start now. So, the moderator is researching what happened because right now we should have the cases that were presented in IMCAS Alert, but instead we will discuss this session with you. So we will describe the problem. We will speak in Spanish. Is that agreed upon everyone? Okay, so this is a 56-year-old woman who has practiced mastopexy, and she wanted to cover her scars with tattoos around the areola and the mammal area. She asked for a darker shade and a lighter shade. And I will tell you the problem or complication. Following image, please. This is the problem. The color tone changes after the first laser session. These are normally made out of iron, and so these changes state. And we have a red pigmentation. And the white tone is obtained as of titanium, and titanium tends to change to gray, and therefore it's very, very difficult to eliminate. So if you see downwards, after multiple sessions, at least 15 sessions of treatment, I've achieved what you see in the lower image, which is not pleasant, and that's what I've achieved up until now. And I want to ask to my expert colleagues to know what they would do. All right, so can you hear me? So what type of laser did you use? All right, so I have 2 peak second lasers, psycho switch, and I used first instance wavelengths of 9.4 millimeters, and I started with fluencies of 0.5, and I increased these. I think the last sessions I was already applying 2 joules per square centimeter. After, I had to change to G32, and this was in the areola and the vertical scars. And when we're too aggressive, we create these type of scars. These are provoked by me, and I have the rest of the titanium that is quite difficult to remove. Well, you know that when we have these type of scars, and whenever we are going to carry out a revision with laser, well, because in general terms we receive different types of scars, but we will talk about surgical scars, which are the most complex. We perhaps should resource to the Vancouver scar scale, which talked to us about applicability, color and texture, and also applicability, texture, and also size of the scar. Size of the scar, if this is atrophic, pseudotrophic, and colloidal. So in this case, I believe this is actually the first time I see after a surgical scar that this could change to such a difficult color to treat. I didn't put this in the initial presentation, but the patient requested for the surgical area to be tattooed. I apologize, you were delayed and didn't hear this. So there was a blacker tone tattooed in the areola, and then we have a dispersion of color and white on the rest of the scar. So the blacker tone passed from the ferric state to a ferrous state. And for now, she was pleased with serotonin, and I said, okay, let's not treat this anymore. And the problem was the white tone, which is based on titanium, and this is what happened. It turned to gray. And trying to eliminate it, I am responsible for the lipoderma. I will tell you a bit about what I did, and I hope that Jorge replies, and then I can further explain the case. Well, to be honest, with these new trends of doing microblending and eliminating, for example, stretch marks with pigmentations, this new trend is truly creating a problem for us, because at the end of the day, well, honestly, when we really need to carry out a change of the scarring structure, you need to scar again. Therefore, you need to create micro scars within the scar to give a second opportunity to this whole situation. Now, the situation is no longer there. She has a different pigmentation to her natural color. And therefore, this will be much more noticeable. And as we said yesterday, we don't know the quality of the pigmentation that is being used. And in general terms, pigments will not be standardized. So actually, after reaching new colors, pigments are combined, and that's where we have this problem that you just mentioned that you're facing, which is that color changes. What I see is that the evolution was not negative. For example, if we compare the initial color to the red color, and then this color is much more similar to a natural color, well, the hypopigmentation areas, I think that this was forthcoming. With several sessions, this is something expected. And I would choose, in this case, I would try to treat it, as you said. Well, if it's about scarring, we should talk about the area to be treated, and this should be treated as a hypertrophic scar. And perhaps from the same skin, we can create a regeneration so that we can really try to smooth out this pigmentation. So what did I try to do? I applied CO2 to transfer blood clotting, and I could create post swelling pigmentation and try to get another color as a result. And I used promoted procs, but that's off-label. It's not proven. Although perhaps it affects pigmentation of eyebrows. Perhaps it could work here, and this was not successful. So, but I must say that, well, Flor asked us, right, as experts to give our opinion, but you are also experts. Perhaps among the audience, do you have an opinion about how you would have treated comparing photo 1 to photo 2? And perhaps we could have an interaction with the audience as well. Could you go back to the first photo, please? Well, this was the initial color. Yes, understood. So this is the first photograph. They will hand you a mic so that, please remember that we're in IMCAS Live and there are many people who want to hear you. So I don't really understand. The initial pigmentation that the client requested when this first scar was created was to perhaps attempt to camouflage the scar, and then that pigmentation became darker. No, she asked for a dark tone, and she didn't expect it to be this dark. And she asked for a white tone, and she wasn't expecting it to be so white. And when I apply the Q switch, this changes. And even having said this to the patient, I didn't expect this color change to happen. And well, I want to just ask for your help. So I do agree. Well, if you as a doctor already applied fraction CO2, yes. Yes, I applied that. Yes, this is my patient. Yes, I already applied fraction CO2. So we are really, and this is the last photo, the most recent photo. Yes. So this is the first photo. Here you can see the date. We started on 2018, and this is the date. Go to the following one. This is 24th of February. So 3 years treating this patient, yes. And it's not that I've treated her every month. Of course, I've waited for some time so that the skin can remodel and repigment. And of course, the patient has an anxiety level that is quite significant, and we're trying to manage it this way. So I just wanted to know if this is the current state of the patient. Yes, it is. So the 24th of February is the last time I saw her. So I would actually suggest to try to treat the scar with fractioned radiofrequency with microneedles. I think that's a good idea with growth multifactors, because I think that's another good option in drop delivery when there are scars or hypopigmented scars. If she does not respond to certain drugs. Actually, it's about to try to regenerate the melanocyte in the area that is pigmented. Yes, but we're talking about scarred tissue. Yes, I work on scars. So it will grow. You say that this tissue can grow in the scar? Yes, it can. So what I've done, for example, in cases of burning, which is very common to see hypopigmented and atrophic scars, aside from this, when I don't see that there is a response, I try to do growth factors by drop delivery. And what you're doing is creating this from the deeper surface so that you can see the repigmentation in the surface, which I imagine that, well, of course, you are concerned because you said, okay, I created a hypopigmentation effect that was not there in the first place. So if that is the concern, as I see that in this moment there's higher concern due to the hypopigmentation, well, I think that could be a good option. Now, I have a question because I think that this case is very interesting, and we just left a scenario of having a complication of color with a laser, and we sought other regenerative techniques, and we're not talking about laser. Well, we're talking about radio frequency and using electromagnetism and growth factors that, of course, are favorable for everyone, right? But how many of you own fractioned radio frequency devices? 1, 2, 3, 4, 5. All right, so how much energy do you apply so that there is migration of the melanocytes? That is very interesting in terms of the energy power levels. I think we seek to stimulate them and we don't seek them to migrate. Yes, well, the growth factor is for this migration, which is seeking this micro generation, and it's the simplified effect on the surrounding cells, and that is exactly what we seek when we are treating a scar, because that is a hypopigmented scar, right? And surely, well, I don't know the texture, how it feels, but perhaps when we palpate, there is atrophy. Well, that's my following question regarding the texture. If the texture is atrophic, yes, the texture is atrophic. And where there's also evidence, perhaps something that could be of easier access in certain offices or medical, which is MNL, Omics, well, those are, we're talking about highly or costly equipment. Some have excimer. Yes, you need more resources. Or, for example, low energy lights, LED lights. Yes, this is much more about biostimulation. That's a good solution. I don't have that equipment, but perhaps I can seek it. Yes. Perhaps you need a sugar daddy that can get you the excimer, but truly, in terms of the proliferation or the migration of melanocytes, etc., that we're trying to evaluate what would be the actually also most economic option of the oximer to treat vitiligo. We see that there are ablations at the borders, for example, and that's creating, for example, hyperpigmentation due to heat excess. I sought that with the application of CO2, and when I chose the parameter, I thought it was better to clot rather to ablate and create enough heat. And what I was seeking was not the achieved result. The scar was too atrophied and it did not respond. But I think those are all optimal solutions or options, and it's worth thinking about them. I think the excimer would be ideal, but I don't own it. But perhaps I can take her to someone who does have it. We could say that this lesion, we could say this to the panel joining us, and I as a moderator on behalf of my colleague, well, we could perhaps say that your first option, physician, and your first option for you as users, what would that be? A Q switch? A light? In the first session, if the patient is referred to you, and this is the current state of your patient, and you see her like this in the first session, what would you say to the patient? They will take you handheld mic. 1 second. Please don't fall taking the mic. And what about a treatment with a 535 to remove that pigmentation? A 532? 535, a 535 laser. All right, but for a 532, I would seek the pigmentation scope of yellow, red, and orange. But I didn't seek that at the initial stage. I sought a blacker pigmentation, and I used M64. In the white part, I would have used 1562. This is a question for you, actually. Yes, that could be the case. So that will be a Q switch. But for example, when we remove tattoos with Alma laser of 4 millimeters to remove tattoos, that's what we use. Yes, that's all right. And we could start with, for example, 500 millijoules in the first session, and according to the initial response, we could increase or not the fluency. Yes, even so, it did change, and I normally start, that's a good advice, I use less to more, or I increase intensity as I go further in sessions, and I apply 15 millijoules. But this changed drastically after the first session. Aside from all this, perhaps taking into account the hypopigmentation areas, I think another additional concern is to keep on applying laser in further sessions. And perhaps hypopigmentation can continue to occur, which could actually be more unpleasant than the pigmentation, than the color itself. Yes. So my first priority was to remove the color, the grayish color to which it changed to, and I ended up with this hypopigmentation, which is the largest concern of the patient. And why didn't, when it was already hypopigmented, why didn't you apply a fractioned laser? Well, we applied it and I did not have a good response. The skin was already atrophied. But non-ablative one, non-ablative, in more sessions, in a high frequency, and normally to those patients, you can stimulate them, for example, with a 308, or additionally, apply topically fluoxetine. I don't like to use immonidine because it doesn't really provide a good response. But normally, even if it's non-ablative, I apply a drop delivery. Yes, I did try with imatropros and with an off-label effect, but I did not have a good response. And the drop delivery, I did it with CO2, creating micropaths. I have a non-ablative equipment, which is a Q switch with focused points, and I did not try that one, for example. Or the fibroglass, 550. Yes, 1540, 1550, 1565, or even if you have, for example, in 1927, I think that any of those Ebrian glass could work. I don't have those available, and as non-ablative, I place the focal point that creates these paths within the dermis, but I also have the fractioned equipment, and we will try to do it. We'll try to do a drop delivery with the fraction and with 0.2. These are all ideas that, of course, hopefully when I arrive to Buenos Aires, we can try. Doctor, do you want to come and moderate? I have a question. Yes, of course. At any given point, at some time ago, I read an article in which, for pigmentation, some doctors proposed to use a Q-switch laser combined with a CO2, with the objective that MTZs, when being released or eliminated, could actually drag a bit of the color, and that was showing or proving a significant improvement in color. Perhaps it would be worthwhile when starting to carry out these type of treatments that perhaps is a bit more aggressive, that could avoid this hyperpigmentation. Yes, well, the work that you mentioned, which is creating micropaths with CO2, and supposedly is as if opening, let's say, chimneys, and so with the lymphatic drainage network, it would help really be released through those paths. But the illuminatic factor does not really convince me, because it seems difficult for me to understand that once the pigment is broken, it can migrate through the channels. But it could be a possibility. Actually, we already had this discussion exactly 24 hours ago. But perhaps we can continue it. Well, actually, some patients that I see, for example, specifically patients that come from other centers, and I treat them, I do carry out a CO2 treatment at the beginning, and I do it before, meaning this narrative of the bubbles and tattoo removal is a lie. Forget about it. That's all BS for those people who don't know about this. And then they apply CO2 later to avoid the bubbles and to avoid creation of bubbles. That's because they have no idea what they're talking about. In my opinion, depending on the equipment you have, you can do it with laser, fractioned laser, be it ablative or non-ablative. Of course, non-ablative can provide better results because the column will be much more complete, and it will increase exposure. Many people do it firstly, be it nano or peak seconds, and then pass fractioned laser. However, some time ago, people said that they could do this so that they could go over again, break the bubbles, and have a second or third go with the laser. But no, the reason you do this is for you to be able to have the column and for the pigment to be released. I have another opinion. I think that there are people who are on the other side of the debate, and they basically defend that they can use an RB50, RB05. I don't want to fight with my colleague. We're live, so that wouldn't be nice. But perhaps you can be in the middle. And no, I believe that the RB20 technique does not work. I actually tried it many, many times. And RB20, for those of you who don't know, basically you did one pass with a laser. You waited for 20 minutes, a second pass. You waited for third time, and it didn't really work. I have very, very little experience with the sprays and the gels that exist for tattoo removals, which are in trend in the US and Europe. Basically because the cost increase is very significant for us. I don't know if you know what I'm talking about.
Floro, yes, sí. Exacto, entonces la usé, no vi ninguna diferencia tampoco y la verdad no compensaba el valor, dejé de usarla. No sé si alguien tiene alguna experiencia con
los parches de PFD.
Con los parches o con el spray también que había antes.
Bien, eso no.
¿Tú lo has usado, Íñigo? Y no lo recomendaría, es decir, no me parece que tenga diferencias. Pero sí he visto en los tatuajes refractarios, así les haga uno pico, les va mejor abriendo. A mí particularmente me gusta más con ablativo.
Claro.
Pero pues si no lo tienes, si tienes un no ablativo, pásaselo, igual le va a ayudar. Bueno, ¿qué te dijeron? No me la cargó.
Oh, Dios.
Cárgame.
Si no,
¿puedes cargar la del doctor?
Si no, seguimos con...
Un momentico.
Porque está grabado.
Sí, hay gente que está en vivo que necesita oírte.
Bueno, acá disculpan, yo llegué tarde a la charla, pero tengo una pregunta adicional a lo que están hablando. Cuando vamos a trabajar tatuajes cosméticos, pues no tengo experiencia en este manejo. Igual corremos pues remoción de ceja.
When we are dealing with tattoo in this field, cosmetic ones, is a frequent common of consultation, like for example the tattoo for in the lips or in the eyebrows. What tips can you give us as experts in order to avoid complications or be more prudent with these sorts of treatments? Well, we've got the answer. We were talking about that yesterday in Sandoval also. Don't be afraid, because they are made based on iron from ferrous to ferric. If you're going to anticipate that if there's a blackish or grayish tone, it's going to move, it's going to shift to a reddish or a brownish one, and it's going to be effective. No problem. In Argentina, we are afraid from the white, because titanium is a headache. It's better not to treat that patient. So the topic is, as the colleague also said, that nowadays they mix colors and mix elements, and they say this is art. You know, they are really artists, and they like to do this. So in the tattoo that is dark, you find 4 or 5 white lines. So when it shifts, you realize that it had titanium and it's a headache. Often, in order to evaluate the treatment that we want to do, we're going to take into account the time the tattoo has been on the skin, because a cosmetic tattoo, they say it's just 2 years. This is not epidermic yet, and we might not use an ablation.